Got it. All right. Okay. Okay. Good evening, afternoon, everyone. Thank you again for joining us for this lecture. I will be talking about nitric oxide and the use in neonates. The objectives for this talk is to describe the mechanisms of action of inhaled nitric oxide. We'll also discuss the recommended clinical indications and contraindications for nitric oxide use in neonates, discuss initiation, dosing, and weaning protocols, recognize safety consideration and potential toxicities. So background on nitric oxide, it is a selective pulmonary vasodilator, which means that it is only going to target the pulmonary system and will not generally cause systemic reaction where the babies are and experience any hypotension because of the the relaxation of the vessels. Nitric oxide is used in hypoxic respiratory failure associated with pulmonary hypertension, PPHN. It improves ventilation perfusion mismatch, and it also should be initiated after an echocardiogram has confirmed the presence of PPHN, if at all possible, but do not delay care waiting on an echocardiogram if that is not something that is easily and readily available to you. Mechanisms of action of nitric oxide. It is produced from L-arginine by nitric oxide synthase. It is diffused into vascular smooth muscles and it activates the guanine catalase. I'm sorry for there. And it leads to vasodilation. And again, it is selective pulmonary vasodilator without the effects of systemic hypertension. Indications are generally for late preterm and term infants with hypoxic respiratory failure despite optimal ventilation and oxygenation strategies. Preterm babies less than 35 weeks as a general rule, but we do use nitric oxide in babies that are less than 35 weeks, and we have seen some good results from using nitric oxide in these babies. BPD is another indication with pulmonary hypertension, and it can be used to rescue if there's severe right ventricular failure. Babies that have congenital diaphragmatic hernia are also able to be given nitric oxide. And it does help in many cases in pulmonary hypertension caused by different causes, such as these that I've talked about before, BPD, diaphragmatic hernia, or sepsis. Generally, we would like to have a target of, say, an oxygen index of greater than 15 to 20. And later on, I will show you some calculations to determine oxygen index. So PPHN is persistent pulmonary hypertension of the newborn, and that is a failure of normal postnatal fall in the pulmonary vascular resistance. That's the PVR. So the baby is having fetal circulation, and once the baby is born, they should transition into getting rid of this high pulmonary vascular resistance and be able to come out of fetal circulation. Right to left shunting at the ductus arteriosus is generally where the shunting occurs, or it can be at the PFO as well. And this leads to severe hypoxemic respiratory failure despite adequate lung inflation. So persistent pulmonary hypertension, this is also called fetal circulation. And you see the normal circulation that is supposed to occur after birth, where the PVR drops. And so you get a good mix of where the blood is diverted normally, and then goes into the ventricles and gets pushed out to the body. And that should be bright oxygenated blood. Whereas persistent pulmonary hypertension, a lot of this blood is bypassing, and you're getting a lot of deoxygenated or poorly oxygenated blood that is getting circulated into the body. So in the fetus, the lungs are not used for oxygen because the baby gets the oxygen and whatever else it needs from the placenta through the umbilical cord. So blood takes some shortcuts to bypass the liver and the lungs in utero. And so the key steps here are that oxygenated blood from the placenta travels through the umbilical vein, bypasses most of the liver through the ductus venosus. Then it goes into the IVC and into the right atrium, and blood goes mostly to the left side of the heart. And most of the oxygen-rich blood passes through the foraminal valley and it goes to circulated and out and into the body. And blood from the upper body returns to the right atrium via the SVC, the right ventricle, and the pulmonary arteries. Because the lungs are not working properly, most of the blood bypasses, not working properly, sorry, the baby is not using the lungs primarily for this reason in utero. Most of the blood bypasses the lungs through the ductus arteriosus into the aorta, and then it goes to the lower body and umbilical arteries back to the placenta. So it's a cycle of blood that goes through. So the key shunts here are the ductus venosus, it bypasses the liver, the foraminal valley to the right atrium, left atrium, and ductus arteriosus, pulmonary artery to the aorta. So just a little bit of a diagram here to show you the basics of fetal circulation. And as you can see, the placenta is here. Everything is going to the body, into the arteries and veins inside, and bypasses most of the things that may cause improper breathing. So pathophysiology of PPHN, there's a high PVR, and that leads to increased RV pressure, and that leads to right to left shunting. And so there is decreased pulmonary blood flow, poor oxygen uptake. And so this is simply just saying that the oxygenated blood is not getting routed through the vessels and out to the body. So there is persistent, again, fetal circulation. And there will be systemic hypoxemia, there will be acidosis, and just a vicious cycle of worsening pulmonary vasoconstriction. And it just goes around and around until you stop that cycle and do whatever it needs to be done to get this baby out of the fetal circulation. Again, I mentioned earlier some of these pathology of causes PPHN could be things like meconium aspiration, sepsis, HIE, asphyxia, and pulmonary hypoplasia. From different reasons, it could be a diaphragmatic hernia where the abdominal contents are pushing up onto the lungs and it's not developed properly. So hemodynamics, again, elevated pulmonary pressures greater than systemic, right ventricular overload, and dysfunction may occur as a result. Left ventricular filling is impaired, so there's not enough filling going on in the ventricle, left ventricle. So then you'll have decreased cardiac output. And the result of all this is hypoxemia, metabolic acidosis, systemic hypertension, and these babies can be very, very sick. So they may need a lot of support with mechanical ventilation, fluid therapy, as well as blood pressure management by given medications such as dopamine, dobutamine, if there is dysfunction of ventricular dysfunction as well, um, and other pressures that can be used, like epinephrine, hydrocortisone, but that's a lecture for another day. Diagnosis again, echocardiography is the gold standard, and it's going to confirm elevated pulmonary pressures. It's going to show right to left shunting at the PFO or the ductus arteriosus, and left ventricular dysfunction. And you can also, it's just a poor man's test of PPHN. If there is a pre and post ductal gradient difference that is above 10%, would suggest that there is some shunting that is causing pulmonary hypertension. If you get a blood gas, arterial blood gas, you may have a low PaO2, despite the baby being on high oxygen. So management is to optimize oxygenation and ventilation, correcting acidosis, make sure baby is normothermic and euglycemic, and normal calcium levels. And these babies are very, very touchy and finicky, so you will not need to touch these babies as frequently as you would if it was just a normal baby. So you minimize handling, you minimize stress, and you need to, give the baby sedation if it needs it. We use fentanyl or Presidex that will help the baby stay as calm as possible. And it is also important to not have loud conversations around the baby as well. And just keep the baby's environment as quiet and as calm as possible. And that will help get this baby to heal and to use the therapies that we're giving the baby. Again, talked about nitric is a selective pulmonary vasodilator, so it's going to target the vessels in the lungs and not generally cause systemic hypotension. Um, Nitric oxide, if this fails to help this baby, the next step would be, of course, ECMO, which don't know if that's a service that is offered in your area, but for us, it would be an option for your baby. So this is just a simple little diagram showing a nitric circuit. The nitric cylinder is hooked up to the ventilator, and it goes through the ventilator circuit and all that, and then it gets diverted to the baby via the ventilation. And it's not to say that nitric oxide cannot be delivered by other means, because if you have baby that it's older, it's a term baby that it was a preemie and has BPD, that baby may not be on mechanical ventilation, may not be intubated. It could be on CPAP or ram cannula, where you can deliver nitric oxide by that means. So um, and also be very, very careful to that when, if your baby is requiring some PPV for whatever reason, make sure that the bag mask that you are using for this baby is also connected to the nitric, because you want to continue nitric no matter what. If you are baby is intubated and you have to do something where you have to give some positive pressure, you should be delivering nitric oxide as well during those times. So the initiation and dosing. The term and preterm babies, we generally start at 20 parts per million, but could go up to 40 if no response. I can honestly say I have never really gone above 20 in most of the cases. But there is literature out there that suggests that it works. So it's a case-by-case basis, and you have to decide on what is best for your baby, and you will try to do everything you can to help this baby get out of this pulmonary hypertension. So again, it says preterm babies less than or equal to 35 weeks. It starts at 5 to 10, with max of 20. We start at 20, generally speaking, for pretty much every situation, at least at my facility. So um, even the babies that are preemie less than 30 weeks or what have you, they can have some benefit from nitric oxide. And then it usually works very quickly, within 30 minutes to an hour. But if the baby is not responding to it, then it's not therapy that should be continued. And it will, again, typically require mechanical ventilation, but can be done using CPAP. So as far as weaning protocols go, once your baby has been settled and demonstrating that it is improving, and you are able to wean FiO2 down to 60% or less, then you need to start weaning. And if your PO2s are within range, as well as your pre and post ductal saturation goals. Some practice differently. There some physicians and practices and providers will tend to use one criteria. It may be that you're using a target ductal sat greater than 92%, or it could be 95%, or you may be winning by the PO2s on the arterial blood gas. But if you do not have arterial blood gas, then kind of forced to wean by SpO2, which in either case, the end goal is being able to wean the baby from nitric oxide. So if while in the weaning process, say the baby was on 20 and you wean to 10, and the baby starts deteriorating and doesn't tolerate it, then go back to where you were previously, and then give the baby time and reassess before trying to wean again. So just a quick little chart to show you the initial steps. You begin at 20, and then you start weaning once the baby has met stability criteria. Generally, you go from 20 to 10, and then from 10 to 5, and after 5, you go 5, 4, 3, 2, 1 until the baby is completely off the nitric oxide. So, weaning generally is about every 4 to 6 hours if the baby is doing well and is stable. And wean your oxygen as well before you start weaning your nitric oxide. So again, some people may target once you are able to wean to 60% oxygen or 40% FiO2, then you begin to wean the nitric oxide. And again, every 4 to 6 hours, be slow, be patient, because you don't want to rush this baby and then have some rebound hypoxemia. So just a quick little chart here that shows you how to wean. Again, 20 parts per million, you go to 10. If your FiO2 is less than 60%, or the target goal that you decide may be 50%, maybe 40, but whatever it is, be consistent. Or your SpO2 is greater than 92%. So every 4 to 6 hours, you would wean. And again, you go slowly. Once you get to 5, you go 5, 4, 3, 2, and 1 part per million, while you are observing for any effects of rebound. And again, if you do see some rebound, go back to this no number you were prior to that last wean, where the baby started having some adverse outcomes there. Safety considerations would be nitric toxicity. baby can develop methemoglobinemia, which has a very strong affinity for oxygen, and this can cause your baby to be hypoxemic. And generally, you would target, greater than 2.5%. You would be in that range where this baby might have some toxicity to this nitric oxide. So obtain a level prior to starting nitric so that you have your baseline, so you know exactly where you're starting. And then every 24 hours after initiation of nitric oxide. Should also make sure that your baby's platelets are within normal because nitric oxide can reduce platelet aggregation, and baby might be at risk for bleeding. And especially very, very important to, your premature babies that might be at risk for intraventricular hemorrhage or pulmonary hemorrhage. And nitric oxide in high levels can also cause some surfactant dysfunction. And this is just another safety considerations here. It's almost the same thing. So this is something that, you can print and have available to you for quick reference, okay? So again, if methemoglobin levels are high, it should most likely discontinue or reduce the nitric that you are giving so that baby can benefit from it without the adverse outcomes of methemoglobinemia. And this is just another slide here talking about platelet dysfunction. It doesn't decrease the number of platelets, it only reduces the ability for those platelets to come together to stop bleeding. So if there is bleeding, of course, you would most likely need to give something to get that bleeding under control. Such as any clotting factors that your baby might need in addition to platelets. So key recommendations to confirm PPHN with echocardiography. It can be used in the late term infants with hypoxic respiratory failure that are not responding to the optimal ventilation and oxygenation strategies. And routine use in preterm babies are not recommended, but it can be done. And most centers here in the US will use nitric oxide for babies that are less than 35 weeks. It can also help with babies that have BPD, bronchopulmonary dysplasia, that have PAH, pulmonary artery hypertension, and with severe right ventricular failure. Congenital diaphragmatic hernia babies usually can have some benefits from nitric oxide. So you have many options that can help babies that have pulmonary hypertension. And the oxygenation index that I formulated that I alluded to earlier is pretty easy. It's just MAP times FiO2 times 100 divided by the PaO2. So this would require you to have an arterial blood sample to determine what the PaO2 is. And any baby that is, sorry, greater than 15 to 20, you can consider nitric oxide therapy in these babies. So sample calculation here that you can play with. You can put in different numbers here and use different scenarios to come up with an oxygenation index that might help you determine if the baby needs to be tried on nitric oxide. So case scenario 1, we have a term infant that was born via emergency C-section after prolonged decelerations, required extensive resuscitation at birth. APGAR scores are 2, 4, and 6 at 1, 5, and 10 minutes, respectively. Baby was diagnosed with HIE and admitted to NICU for therapeutic hypothermia. Day of life 1, baby developed severe hypoxemia despite 100% oxygen, mechanical ventilation, and baby had an echocardiogram that really revealed pulmonary hypertension. with right to left shunting at the ductal and atrial levels. The baby was started on nitric oxide at 20 parts per million with marked improvement in oxygenation over the next 48 to 72 hours. By day of flight 4, the baby was weaned off nitric oxide as the pulmonary pressures normalized and oxygen requirements returned to baseline. And the baby remained hemodynamically stable and continued protective care for HIE. And this baby may have been given sedation, most likely, as well as may have had the need for inotropes such as and dopamine, dobutamine, whatever pressors that you use to maintain normal blood pressures. Scenario 2, 32-week preemie was born via spontaneous vaginal delivery after maternal fever and prolonged rupture of membranes. The infant initially required CPAP for mild respiratory distress, but developed worsening hypoxemia within the first 12 hours of life, despite increase in FiO2 and respiratory support. Blood culture grew E. coli, confirming neonatal sepsis. Echocardiogram was done and it showed PPHN with right to left shunting through the PDA. And the infant was started on broad spectrum antibiotics at birth. And also inotropic support and nitric oxide at 20 parts per million for severe hypoxemia. Over the next few days, the baby improved clinically. The infection was improving, the pulmonary pressures were decreasing, and oxygen stabilized. So this baby was able to be weaned off nitric oxide over the next few days. And this baby did very well after sepsis was cleared and was able to be extubated back to CPAP. So which of the following primary indications for nitric oxide therapy in neonates? Routine prophylaxis in preterm infants, hypoxemic respiratory failure due to PPHN in the term relate preterm infant, or prevention of BPD. So of course, the natural answer is B, and is supported by evidence that after optimized ventilation and oxygenation strategies. And then next question, when should nitric oxide be discontinued if there is no clinical response? And it is after 30 minutes without improvement, because if it is not helping, then it may possibly harm the baby. Question 3 is which safety concern is associated with nitric oxide therapy? And that would be methemoglobinemia greater than 2.5%. So in summary, nitric oxide is a great drug to be used to help pulmonary hypertension. It is a selective pulmonary vasodilator, and it is to be used in preterm in term or late preterm infants. But again, it can be used in preterm infants less than 35 weeks. Careful dosing, weaning, and monitoring essential to prevent any adverse outcomes with the use of nitric oxide, which is make sure to get the methemoglobin level prior to using, and also during therapy and weaning per the protocol. And also make sure you are keeping the baby as quiet as possible, whether you do it by sedation, you can use pharmacological therapies or other non-pharmacological, making sure baby is contained, developmentally positioned as much as possible, and keeping the environment as dark as you can and as quiet as you can. And also PPHN is to be confirmed by echocardiography whenever possible, But if you do not have echocardiogram readily available for you, do not delay therapy. Initiate the nitric oxide, and you can get the echocardiogram at a later date. So that is the end of my talk, and I do hope that you have gained something from this, and we look forward to seeing you very soon.